And now we're back to July. So this one, we are going to go through kind of basic airway management, RSI, and we'll look through our protocol, discuss some updates that we will do the protocol, and just kind of some mnemonics that you can put in your head to think through for your difficult airways. So we'll review the anatomy of an airway, know what makes it a difficult airway, understand our RSI protocol, our drugs, and our transfer and continued sedation protocol, which I will give you guys here in a minute. And then during our skill session, we will go through making sure you guys know these dosages and what you would use when, based on your patient scenarios. So, reasons why we intubate. Inability to protect or maintain their own airway, failure of oxygenation, failure of ventilation, or you anticipate that they might lose their airway or based on their clinical course. So those would be less pre-hospital and more in the ED or ICU based on they have a bad neuro, head injury, bad sepsis, those kinds of things. So what makes an ideal condition for intubation? Perfect lighting, you can position them, you have plenty of helpers, you have time to prepare, plan, discuss with your partners, you have the option to abort your airway, they have a nice empty stomach, and you have backup available. So next level of expertise available to you. The ideal patient has an intact, clear airway, they have big, wide open mouth, they are pre-oxygenated, they have their own respiratory drive, they have normal teeth, good oral hygiene, not teeth hanging off, barely there, clearly identifiable intact neck and face. They have big open nostrils. They can move their neck all around, and they have a normal BMI. In reality, we have immobilized, traumatized, compromised, Hawkeye vodka and pizza-loaded patients. Or your other alcohol of choice, a beer maybe. This would be a potential difficult airway. You look for bubbles, I guess. So, how do we identify a potential difficult airway? You look. So what information do you need to make sure you have to know if you have a potential difficult airway or should have a basic airway? Their past medical history, a basic exam, their thyromental distance, and their Malapati classification. We'll go through all these. So in their past medical history, have they had previous C-spine surgeries? So is their neck not move? Do they have rheumatoid arthritis? Do they have ankylosing spondylitis, which basically just fuses that whole spine and won't let them move? Have they had head and neck surgeries? Do they have a giant scar across the middle of their thyroid? Do they have an old stoma scar present? Radiation to the neck? Or does their family member say, the last time they tried to intubate him, they couldn't get him? Pretty important to know. So I found this when I was doing some research for putting this together, and I thought this was a great mnemonic to kind of have in your brain when you're sitting looking at a patient for their airway. So a lemon approach, and using that mnemonic means you look at them, you evaluate them, you look at their Malapati classification, you look for reasons for obstruction, and you look at their neck mobility. And if you have one of these that puts you in that high risk, then you have to have your plan Bs and your plan Cs ready for your airway management. So in your basic exam, you're looking for anything that limits the mobility of the neck. They have a big goiter here. Are they those ladies that you take out, they're kyphotic, you take out the pillow and their head's still 4 inches off the bed? Those are not going to be easy airways. They have the scars I talked about, big scars across the anterior neck are potential bad. Burns, so singed nose hairs. They've inhaled, that puts their airway at risk. Obviously, trauma to the face. Do they have crepitance? When you feel their neck and shoulders, do they crunch? They sound like Rice Krispies. Those are going to be potential bad airways. Those short neck, the obese patients, or those ones that have the jaw that their mandible kind of sits behind their maxillary, so they have a very short mandible. Those are going to be hard angles to get. So the 3-3-2 rule, greater than 3 fingers from your jaw to your neck. Jaw is greater than 3 fingers wide, and you can open the mouth greater than 2 fingers. Any of those don't fit, that sets you up for a difficult airway. And here's just a review of the Mallampati classification. This is what we all want, that nice class 1. You see their tonsils, uvula, their soft palate, and their hard palate. And you get a great view. Most patients will fall somewhere in here. These, when they open their mouth and all you see is that hard palate, can't see anything back, you know you're setting yourself up for a difficult airway, and you may want to think twice before you go down that airway. So the class 1 view, that nice full view, these are based on anesthesia literature, so it's a little different than ER docs and pre-hospital, but those are 90% successful in anesthesia world. Class 4 is considered a difficult intubation by anesthesia standards 99% of the time. So that's an anesthesia in a controlled setting with backup and every equipment available. What do you think your pre-hospital success rate is going to be on a class 4? Pretty bad. Probably not the guy you want to paralyze. So now we're to we did the L, the E, the M, now we're at the O, obstruction. So they have a mouthful of blood or a face full of blood. Vomit. Are their teeth hanging off and going to be in the way? Do they have a big, huge epiglottis because you know they have epiglottitis and the stridor and they're sitting there perched forward? They have dentures that might get in the way. You know they have head and neck tumors, or they have some object through their head or neck. Impaled objects can be challenging to work around. Sometimes you actually have to cut them if they're in the airway to be able to get to your airway. And then the N portion, your neck mobility. So are they in a C-collar for their spinal precautions? They have impaled objects, so you can't move them because they have penetrating trauma of the head or neck. Lack of access to move them around. And then all those things we talked about in their past medical history that you'd want to know about if they have rheumatoid arthritis or they're the kyphotic lady. So now you know what kind of airway you have. You've gone through. Now what do you do? Well, one, if it's a crash airway, we don't have time to plan, and we just do the best we can with getting an airway in, because that means they're not maintaining and doing well on their own, and they don't need paralytics or sedation to get to it. Those we can't avoid, and we do the best we can with those. So if not, do they have failure or imminent failure of oxygenation, ventilation, or inability to protect their airway? Those are the ones where you get to make the decision of, should I go down my RSI pathway or assisted sedation, intubation pathway, or should I do the best to position, medicate, and get them transported where I have backup? So definition of RSI, rapid sequence intubation, is the rapid progression of an induction agent, which will lead to unconsciousness, and a paralytic agent, which will cause motor paralysis. So to truly be an RSI, you need both of those components. Oops. So why do we RSI? The principal theory is we have better success if we RSI them than wait for them to decompensate, and you have better success in a controlled environment. The secondary rationales are you get better ceasifying control, you blunt their ICP pressure response, you hopefully avoid airway trauma because they're paralyzed and you don't have movement of their cords. You decrease their pain and their discomfort associated with intubation, and hopefully it minimizes the risk of aspiration as it's controlled. The big hazards of RSI, prolonged intubation attempts because they're paralyzed and you can't abort it. Adverse drug events, and we'll go through succinylcholine since that's mainly what we carry, and the adverse effects of those. And this is kind of an irreversible commitment. You go down that path, you got to plan on getting some sort of airway in it. So it's not something to be taken lightly. You can't reverse your decision once you make it. So there's kind of a way to think of it of 7 Ps of RSI. And this is kind of, literature shows a scale of 10 minutes prep, to 90 seconds after, and that's if you're saying one attempt. So your 7 Ps are preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection and positioning, placement and proof, and post-intubation management. So to prepare, you need to be asking yourself, can I bag this patient? Do I think I can tube this patient? And what alternative airway can I provide for this patient? So those are the kind of first things when you look at that patient. My experience is I had a guy with a laryngeal fracture, I suspected. He was a trauma, ejected from a semi-tractor trailer. He had crepitance everywhere, major facial trauma, and an unstable feeling, cricoid and larynx. I decided I may not be able to tube that patient. So I didn't want RSIM, and I had anesthesia present to do a fiber optic potential intubation or a surgical airway, because I was not confident that I could, one, bag him with his massive facial trauma, or that I could tube him or cric him if he had a laryngeal fracture. So there's times even we don't feel comfortable bagging or tubing a patient. So I'm looking for somebody else with more skills than I have and more techniques. So you need to ask yourself, if I can't do these things, I should not be RSIing this patient. So then, is all your equipment present and working? All your planned airway supplies for that patient? Do you have suction? Is it working? And do you have your plan B airway supplies? Because you always need to think in your mind, I may need plan B. Not, crap, I've looked 3 times, I can't even begin to see cords, and now I'm digging through the boxes trying to find my king, or my cric if I need it. Whatever other plan B you have, that needs to be readily available, not shoved in a cabinet somewhere after your 3rd attempt and a pulse ox of 60%. So you decided, can I tube them? You reviewed your criteria. You agree that this is a plan. Here's all your backups that you can have readily available. So you've got your oral airway. Can you just bag them? And this, our King Vision can be determined if that's really a backup or if that's going to be your go-to plan. So may not really be a backup for some of you. Do you have your bougie when you can't see and you can feel? And do you have your king ready? And you could put in there the needle airway as well, but I have that in plan C. So next step is pre-oxygenation. So this is about 5 minutes before you're going to push your drugs. Don't bag these patients unless they're apneic. Otherwise, all you're doing is filling that Hawkeye vodka and beer belly and pizza belly fuller and fuller, waiting to get vomited on. So I see RT do this. I see everybody want to just get in and start bagging the patient before you've even pushed drugs. Just get them oxygen. So put your nasal cannula in place and have your oxygen mask or your bag valve mask over them. Both. And we'll talk about continued oxygenation while you're intubating, but have them both on there so you're not trying to flip to your nasal cannula afterwards. Put your cannula on and your mask or BVM. Here's why we pre-oxygenate. I thought this was kind of interesting when you look at the curve. So that first curve on the left is an obese male. Then you have a normal kid, moderately ill adult, and a normal adult. Look at how quickly those obese patients lose their oxygen saturation. You do not have much time in a normal resting patient that's not pre-oxygenated to tube. And who are the tough ones to tube? The big fat people. So this is why we pre-oxygenate. You want to try and get that shifted over as much to the right as you can to give yourself as much time as you can. So you need a well-fitting mask. If you have a nice controlled setting, they get at least 8 full vital capacity breaths. So whether they're doing that on their own, typically that's anesthesia in the OR, they just have you take those big deep breaths, or if you're bagging, get good 8 breaths in if they're apneic. This allows all that nitrogen wash out and the quote oxygen wash in, so you give them as much time as they can before they're going to desaturate. Okay, now we get on to pretreatment. This is something that's changed in the 10, 15 years I've been practicing. Lidocaine, we used to pre-medicate with lidocaine all the time. Now, pretty much is gone by the wayside. There's no literature to support that really has any effect. Opioids, these definitely can help with that pain response, especially in the patient you are RSIing for their head, bleed, airway protection. They're not in dire straits of losing their airway. You're doing that kind of prophylactically. So this is when you get called to the ER. You're helping with a trauma patient, and we decide to tube them before we fly them to Des Moines for their head bleed or whatever, or before they go in the back of the rig so they don't lose it. It's really nice if you can give an opioid before, because this hurts. And just be aware of your apnea and your hypotension. Atropine is really only for kids anymore, and it helps blunt that bradycardic response that they get from the vagus nerve from their intubation. So there's their dose, 0.01 to 0.02 milligrams per kilogram IV. And remember, you have to give these like 3 minutes before. If you push them, and then 20 seconds later you're pushing your etomidate, and then 50 seconds later you're pushing your sucks, you can't get your atropine to do anything. You have to give it time to circulate and work. So you want to try and give that 3 minutes before, or let your fentanyl kick in if you're doing it for pain control. And so our induction agents, big one we talk about and use most is etomidate. Thiopental is anesthesia used. I know Curtis Waite trained with it, and he uses it more. And then we have our ketamine, our propofol, and our Versed or midazolam. Kind of talk through our protocols and different ones we'll use here in a minute. And our paralytic agents, the only one we carry for true RSI is succinylcholine in our transfer bags, and you may have a doc ordering it on the floor if you're intubating in the ER. Up on the floor is ROC or VEC. ROC is pretty much what we carry here. So for induction agents, etomidate is kind of the go-to drug of choice still in the literature. In our protocols, we talk about sepsis and avoiding it. That was kind of a big deal 4 years ago. Now, maybe not so much. Caution with sepsis. Still have other drugs you can pick if you want. The whole theory behind it was etomidate suppresses the adrenal glands, which worsens sepsis. Now, that was kind of one study that was a big study. Now there's a few others that say maybe not. So 0.3 milligrams per kilogram, max of 40. And I believe that's probably the max in your drug bag for your RSI, unless we carry 2 doses. You have to draw up, but there's still 20 a vial, right? Oh, it's just 140. Okay. So your max that you'll give is 40. And almost all patients, you're going to hit that 40 mark in your dosage. Ketamine is another option in there. Theoretically, it's good for asthma and penetrating neck trauma, helps dry up secretions a little bit. You don't want to use it in known head trauma with ICP. It'll raise your ICP a little bit, so avoid that in major head trauma. But if you prefer that one, that's fine. Won't drop your blood pressure like the Versed. A lot of literature showing that it's just not a great inductive agent anymore when we have etomidate and ketamine as other choices, because it causes so much hypotension. Most of these patients are already hypotensive for whatever reason. And so you can give smaller doses and procedural sedation without the hypotension, but to get an induction dose at 0.03 milligrams per kilogram, you're getting a pretty hefty dose to cause hypotension. So probably not your go-to drug. We have it, but wouldn't be my first or second choice of induction agents. And then sucks versus rock. If you're just hearing somebody make the decision in the ER, up on the floor in the cath lab, which drug they want to use. Remember depolarizing and non-depolarizing. Onset's going to be 45 seconds with sucks, a minute with rock. So not a big difference in your onset there, but your duration. Sucks is going to last you 9 minutes, rock's 45. So, and there's your dosages there, 1 to 2.5 in sucks and 1 per kilo in rock. So it's a little bit easier dosing in the rock. Big thing to think about, though, is if you know your suck's going to wear off in 9 minutes, they're going to start potentially moving, and you'll know that they're having their pain response and they're trying to pull at the tube or whatever. Rock, you've paralyzed them for 45 minutes. If all you've done is given your etomidate induction dose and no opioids or sedation, all of a sudden these patients get hypertensive and they're locked in and they are aware, but they're paralyzed and can't move. So you have to remember, if rock's been given before you're transporting somewhere, get your opioids, get your sedation, continue, because for 45 minutes, all you're going to see is that increased heart rate and blood pressure and no movement as they're paralyzed and locked in. It's a pretty miserable thing to think about, being completely paralyzed, but somewhat conscious and aware. So reasons you wouldn't want to give the sucks is if they're known hyperkalemia. So perfect example of when you could have to take over an airway is, we're doing all these transfers from Marshalltown. They have a lot of renal failure patients, and that's why they're coming here, because they need dialysis. They go into heart failure, and you want to tube them. If you've got a lab value that says their K is like 6.5, probably not the drug you want to push, because then you may be seeing torsades or VTAC on your monitor shortly after, because it'll push all that hyperkalemia, that potassium out of the cell into your plasma. And rhabdo, kind of similar pathophysiology there. The other is kind of post-trauma patients. So we're not going to see as many of these here, but the subacute burns, so they had a major burn, they're in a burn unit, and a day later they need airway protection. You don't want to use succinylcholine in those patients. They've got a spinal injury, subacute, so a day or two later after a quadriplegia or paraplegia, that's not the drug to use. And if you know they've had malignant hyperthermia, very low likelihood that you're going to know that pre-hospital. But if the patient or family says, they can't have paralytics because they got really sick after the OR, probably don't want to give a paralyzing agent. So just kind of the depolarizing and non-depolarizing, your succinylcholine is your depolarizing agent. It causes persistent depolarization because it completely blocks that receptor at the neuromuscular junction. One thing I thought kind of was interesting to think about is these go through the large muscles first, so your limb muscles, and then goes up to face and ears, and then hit your respiratory at the end. So you almost can see that when you push sucks. You'll see their arms fasciculate, and then you see their face twitch and their eyelids, and then you'll get your respiratory depression, where your non-depolarizers work the opposite. They start centrally and kind of work out, but respiratory are always the last. You cannot antagonize the succinylcholine, but you can do that to your non-depolarizing. And these will be, your depolarizers will lead to flaccid paralysis. They have no tone. Initially, in your non-depolarizing, they can stimulate action and then have paralysis. So just kind of knowing if you're seeing a difference when somebody pushes rock versus somebody pushing sucks. Okay, so that's through the paralysis and induction of the Ps, and now you're into production and positioning. So theory, 20 seconds to intubate. So get them in the right position, get your angle, and cricoid pressure is, in theory, what we should be doing when we RSI. Theory that it decreases aspiration. Some studies show maybe it doesn't, but if you can, a gentle pressure on the cricoid. Making sure you're following your C-spine precautions. And then kind of just basic to think about all your axes. You want these lined up so that your best option is to hit your airway, not your esophagus. So getting the patient not flat, that sniffing position. We kind of talk about if you can move them and they don't have a rigid neck and they're not up off the bed, and it's hard to get that perfect position. So this is the view we all hope for. I don't know how many times I actually get to see that. It's a rarity. That's what we're all hoping for. I tried to find a great, bloody, messy picture, but there wasn't anything great on the internet that said the view we normally get. So once you see that and you're through the chords, you need placement and proof. So 45 seconds that you're in their airway, and then you're proving it. So did you see it go through the chords? That's number one. If you saw it go through the chords, it better be there. Bilateral breath sounds, you can get fooled. You can hear enough bagging that I've heard what I thought were breath sounds before, and they're really in the stomach. So that's not 100%. What is 100%? Getting your end tidal on. And we have a whole capnography lecture we'll go to tell the difference between esophagus and endotracheal placement. And then you've confirmed you have good end tidal waveform. You secure your tube with whatever device, and then you adjust ventilation based on your end tidal number. So remember, intubation hurts. It is not something you want to wake up and be aware that you have had. So biggest thing is maximizing your pain meds. Get some fentanyl on board, Dilaudid, whatever narcotic they need. Maximize that their blood pressure will tolerate. So when they're waking up, they seem restless, they seem agitated. Your first line is get some pain meds on board. Then your second step is add sedation, and we'll pull up that transfer protocol. So all your plan Bs have failed. You can't bag them with an oral airway. Your king isn't working, and your bougie didn't work. You cannot get this patient intubated, and they need an airway now. And we have our new ones. I didn't realize we changed out on the truck, so this afternoon we'll play with them. It looks somewhat similar to this. And remember, your scalpel practice doesn't allow you a scalpel, so it's needle and bagging through your placed needle airway. Big thing is just your landmarks you always need to be familiar with. One, can you feel them? There's a lot of patients you can't feel much here because they're so obese. But thyroid cartilage, cricoid cartilage, in between, you should be able to feel that membrane, and that's your landmark where you go. If you can't feel it, shouldn't be randomly stabbing through their neck. So if they've got tracheal disruption or any kind of subcutaneous air, it is going to be really hard to feel that and to make a good landmark, because they'll be crunchy all over and you may not be able to feel that. But that's your goal if you're going for a surgical airway. Okay. Should we take a look at our RSI protocol? We kind of went through all those drugs in there. Uh-huh.
Say we go down the ketamine route.
Yep.
For the continued sedation, you'd be okay. The reason I ask is 500.
Right. It's a lot of volume.
It already ends. Currently not right now. So I was just wondering.
Right, and it's in our, which I'm going to hand out here, our inter-facility transport as either mixing into a drip or just continuous IV. So I have no problem, and we'll write it into probably the RSI or just kind of combine these continued sedation protocols. Hand a few of these out, and then we'll grab a couple more. So yeah, redosing your ketamine, just watching your blood pressure and watching that you don't kind of have a loss in your, a couple more, in your pressures so that they're getting hypertensive on you. But like I said, first thing you'd want to do before you give your ketamine, I got a couple more coming, is getting your opioids on board, is making sure you've got plenty of fentanyl. Did I give you two of the same? Here you go. What do you need?
Take both. 34 and 35.
Okay. So yeah, one of those protocols is your continued sedation, and one is your pain. Because these were written after our original protocols as an add-on once we got the vent. And so we just need to combine them all into one as continued sedation afterwards. Part of it is the drug bags. Some of these drugs are not in our regular bag, but they're in our transfer bag. So that's part of why they got written differently, to get the transfer bag for those continued sedation. Because we don't have propofol or ketamine drips in our bags. Yeah, they're in the transfer bag that you can get. So, yeah, either giving, so after you intubate and you've still got a 30-minute transport, or you're, picked them up from the ER and you didn't grab your transfer bag, and you've tubed them just before we left, giving them a couple doses of pain meds. They're still breathing rapidly. They seem agitated. You've given your benzos, or you can give some ketamine on that. But the big thing is getting your opioids first, because imagine being awake and having a tube in there. It's not a comfortable thing to wake up from. So, and like I said, in here, the protocol has etomidate, not indicated in sepsis. If you guys push etomidate, we'll get these updated. So that's kind of not as studied, validated, I guess, would be the right word anymore. So I'd rather see you give etomidate anymore based on the literature in a septic patient that needs airway management than Versed and bottom their pressure out more. Ketamine may be the way to go, so you don't drop your pressure in that kind of patient, but pick etomidate over Versed, because the last thing you want to be doing is fighting that systolic of 70 the whole time and trying to get back. And then we're adding pressors on when we didn't need them to begin with. And we do have ROC in the transport protocol for continued sedation. Again, that's med control only, whether it's us here or your receiving facility. Really, the only potential time is you're going to Mayo or the U. You shouldn't get to the point where you have pushed enough opioids and analgesics and sedatives by Des Moines that you need to paralyze. Plus, then you're going to arrive with a 45-minute paralyzed patient and not have a happy neurosurgeon versus somebody you've got a 2.5-hour transport time on. But that's absolutely last, because like we talked about, they're locked in, starting to become conscious but paralyzed. You're not going to be making them very comfortable, and they're going to get more and more hypertensive and tachycardic. And really the only time we do that continued here is on our hypothermia protocol. When they're shivering so bad and you've maxed out all your sedation and they're shivering, then you can give them the ROC. Questions, thoughts on airway stuff, our current airway, or anything in the lecture? So I think all of our problem is we're not good at getting the opioids on board first. So I've really tried in the last 6 months to get a propofol bolus in, give them to a Dilaudid or 200 fentanyl or something, opioids to really get on, and then up in their propofol. But that's when sometimes I'll add in a little Versed if their blood pressure is okay on it, or add in like an Ativan. Then it won't drop their pressure as much, but give them a little more sedation. Very rarely do I add propofol and like ketamine, because you're just getting to me in the same category. And now you're bouncing down the road. Right. Right. For sedation. Right. And that's going to be the majority of your patients, when you take them and ramble them down the road and move them all around, they're going to wake up and you're going to need increased sedation. So. Yeah, and if you have your transfer bag, you have Dilaudid in it if their blood pressure can handle that. Because you think about 1 milligram of Dilaudid, 6 of morphine equivalent. So if you give 2 of Dilaudid, you got 12 of morphine on board. And that should give you some short term, and if you're just going to Des Moines.
Well, and that's usually what it is. It's usually like once or twice on the trip.
Yeah, so if you give them 1 or 2 of Dilaudid and milligram of Ativan, that should be close to enough unless they're really waking up and question if they're really needing to be intubated anyway, to get them there without tanking their pressure too much. And bolusing them with fluids if they need it. Anybody else have any other questions? You guys are not a very talkative group. All right, we'll take a 5-10 minute break.